Hi, I'm Dr. Michael Connolly, today with Doc Talks. Our focus will be introducing our medical team and also answering common questions that parents have. So one common question is, how often do I or my team visit with the teenagers here? And the reality in the way I work, I view this as a living, breathing center. We aren't just in a hospital, we're going to school, we're going and having recreational activities. It's a living environment. So functionally what I do is I'm here 3 days a week and I try to make myself available to every teenager here every one of those days. So in that way, there are times when we can have short visits and focus on our schoolwork if that's a priority. There are other times where we'll have a very long visit and somebody has more therapeutic needs. In the end, what I want to teach our residents here is how to be appropriately assertive and advocate for their own needs. We end up doing more of that for them early on, and as they make change, they're the primary focus of any of those interventions toward the end of treatment. One of the other common questions we have is how medication changes work and our approach toward medications. So my team and I would call very conservative. One large reason for that is we are in residential care. Nearly every teenager who comes into our facility has had a number of medication trials. They've been in a number of programs, inpatient, hospitalizations, intensive outpatient. So the idea that Prozac's going to fix everything is not really accurate. We tend to have a couple different entrances from a medication perspective. You have one group that often comes in over-medicated because we were trying to avoid residential care. We have another group where the teenager's been more defiant, it's been hard to be compliant with medication treatment, and they come in on very little. Overall, we tend to leave here on a medication or two. We coalesce toward the middle of that as we're working primarily on developing coping skills, identity formation as a teenager, how to be appropriately assertive, how to work on and manage interpersonal emotional boundaries. Those are all the long-standing core things we'll have to address regardless of medication management. The other important piece is parents or guardians are always a part of the consent process. I don't make a medication change without parents understanding why and what we're doing. So there won't be a scenario where I start a new medication and parents are left in the dark. They will, at times, will email back and forth, at times we'll set up a phone call, whatever it takes so that everybody's comfortable and understanding of the choice, we will do. So another common question is, what percentage of the teenagers at Elevation's Residential Treatment Center are on medication? And the answer kind of ebbs and flows. It's commonly around 80-85%, but at any given time, there may be a resident who we're washing out all the medications. We're baselining. There's a few different wordings that we can use for that, but the basic idea would be to remove the medications that have been used and see what we look like without any, and then restarting if need be. Currently, I've got a few residents who are doing that. Most will not, but if that seems necessary and appropriate and everybody in our team, including parents, feel that that is necessary, that's what we'll do. If we have somebody who's primarily working through therapeutic aims to make change, I don't make a medication change. One of the most common conversations I have in our treatment team meetings is with the rest of the team, particularly the therapist, on what is our trajectory? Are we on a course to leave here, and not just leave, but not need to come back to a program such as ours? If we're doing that work, we probably don't need a lot of medication change, particularly adding medication or increasing doses. On the other hand, if our resident is significantly struggling, the conversation is going to be, why are we struggling, and is that a target for medication management? Another question is, who is part of our psychiatric team here, and how do we split up duties, particularly with the APRN? So at Elevations Residential Treatment Center, we have two primary psychiatric providers. I'm the medical director, and then Lori Crookston is the APRN that works with our team also. Generally, Lori and I will split up cases so that we can give more individualized time in a structured way. Lori and I also work together when there are questions about what to do, how to make a medication change, what direction we should go. She has a wealth of experience. She's done psychiatric care over decades. And realistically, she is a wonderful, wonderful psychiatric provider who can make all the same decisions that I do, and I support her in that. One of the goals we have today is to introduce our medical team. So I am the medical director, Dr. Connolly. I oversee our medical department along with our executive team. And in that department, we have myself, who manages psychiatric medications and am part of the overall treatment team. Lori Crookston is the APRN, who also helps with psychiatric medication and those issues in our care. Jeff Ryan is a physician's assistant who is here multiple times a week managing physical health care needs. So issues such as acne, or we get a bacterial infection or something along those lines, Jeff would have a large role coordinating with parents and ensuring that we have appropriate care. Finally, we have a nursing staff that I would view as more inclusive than nearly any other program that I am aware of. We have available nursing coverage 24/7. Nurses are here all day long. They are the ones that pass out medications. That's not outsourced to milieu staff. They are a part of making assessments and coordinating medical efforts for a wide variety of things. Occasionally, some of our residents need outside specialists for OBGYN issues or diabetes or things of that nature, and they are a large part of coordinating that with families. A few other questions that commonly come up when I am visiting with parents when they're touring. One would be, how should we go through the process? And my role in that is to empathize. You're going through a very difficult time. I, as my career has evolved, view every parent that comes through our doors as having PTSD. We don't end up in this situation having an easy road. So we have to talk about self-care. We have to talk about how to be involved with our children's growth. How do we trust others? Coming out and visiting a program, whether it's ours or any other program, I think is greatly important from a variety of perspectives. Some of that is just meeting people and gathering that treatment alliance and trust. Also working on how are we not going to be manipulated by our teenager who's struggling right now and is not going to be making all the right choices, or maybe distorting what they're telling us. So being here, seeing the layout, talking to people, putting faces to names, I think is hugely important in that process. Likewise, given my viewpoint that most parents are going to have, on some level, PTSD, having your own self-care through your own therapy, I think is greatly important. It also helps to show our teenagers that everybody is in the same village trying to make change, trying to improve, trying to feel better. Finally, we can't answer every question in a talk that is this long. When you have other questions, reach out. Reach out to our admissions team. They will help to coordinate how to answer the question, whether that's reaching a teacher, myself, a therapist to talk about the different avenues we're going on. Reach out, ask the question, and we will be happy to answer.